Good morning, everybody. Today, it is my absolute pleasure to introduce not one, but three Grand Rounds speakers today. The first is someone who I know quite well and for quite a long time, Dr. Shaine Morris. Dr. Shaine Morris is a pediatric cardiologist who wears many hats. It is actually pretty unusual in our field for somebody to be an expert in so many amazing things. Her hats include cardiac imaging, fetal cardiology, cardiac MRI. She is an aortopathy expert and an NIH-funded clinical researcher. Shaine did her training at Stanford University and UT Southwestern for medical school. She also has a master's in public health from Harvard Medical School. Shaine and I actually first met in 2005 when she was my chief resident at Boston Children's, where she was much beloved. She completed her cardiology fellowship at Texas Children's Hospital, as well as an advanced imaging fellowship back at Boston Children's. Shaine is currently at Texas Children's, where she's been on faculty for many years. She is the director of both fetal cardiology and of cardiovascular genetics. And so I'm very excited to have her here today. I'm also very excited to have Mrs. Green. Mrs. Green is the mother of a beloved patient of ours here in pediatric cardiology, Isabella, and she's going to provide a parent perspective as a parent and advocate for her daughter. My pleasure. Heidi Wright. Ms. Wright is the director of the VEDS movement, which is part of the Marfan Foundation, which she joined together with them in 2019. Thank you so much. We're very much looking forward to your talks.
Thank you, Anjali, for the nice introduction. And Heidi's going to start our session today.
Thank you, everybody, for having me today to share with you my daughter's story and our family's experience that led us to the diagnosis of vascular Ehlers-Danlos. I'm just going to give a little background on Isabella. So Isabella is a twin. She was born at Morristown Hospital. She had premature rupture of the membranes at 33 weeks and was delivered at 34 weeks, spending roughly 3 weeks in the NICU for feeding and growing. At the time of her birth, I recall thinking her eyes are so big and her skin is very see-through. You could see all her veins, and she looked like almost like a see-through fish. So within a few weeks from bringing them home from the NICU, she developed an umbilical hernia. And we started noticing like there were light streaks of fresh blood in her stool. There were these unexplained dime-sized bruises that I would find along her thighs and legs. She slept with her eyes half open, and she vomited all the time, multiple times a day. Whatever the suggested amount of food was for her age, she would consume half of that and then eventually throw it up. So I would bring these concerns to the pediatrician, and the response was always, it's normal, she's a preemie. As she gets older, her skin will thicken up. She's growing, while at minimum rates, she's still growing. It wasn't until a year, our 1-year visit, that she completely fell off the growth curve. Even her smaller, lower than normal growth curve. So we were referred to St. Joseph's Hospital in Patterson, along with GI at Morristown. The GI, they did an endoscopy, and I remember the doctor coming out and telling us that wherever the endoscope touched, she would bleed. So that was strange, but now it makes sense. But I remember thinking, well, that's strange. She did feeding therapy at St. Joseph's, and even with therapy, and she started improving with eating. There is still that concern that she's getting older, but I still see her veins, and I see them on her chest. It looks like a roadmap. I see them on her back, on her neck. I would strap her in her car seat, and I would notice petechiae along her neck. small like bruises. At one point, she just fell and slightly bumped her head on the coffee table. So that was an emergency room visit. And the doctor said that he had to put extra stitches to kind of hold it together. So deep down, I felt like something is just not right. I felt that I know it's hard having twins and I know it's overwhelming, but something just didn't feel quite right. So I brought it up to our pediatrician again, and my husband and I were told she's perfectly healthy and all these troubles, she'll eventually grow out of them when she's 7 and 8. And since bleeding was a concern of ours, we were referred to hematology to do a von Willebrand panel. So the von Willebrand panel came back normal. The doctor at that time just leaned over and said, your daughter's perfectly fine and enjoy her. So we did, and we have been, and fast forward through all that, she now turned 8, and all the concerns are still there. And I'm thinking in my head, the feeding has gotten better, her vomiting has gotten better, but it's toned down, but everything else is still there. So I did some research. Don't cringe, but I did some research on Google, and VEDS came up, and she checked off all those boxes. I mean, sleeping with her eyes open, lobeless ears, the visible veins, and even just looking at the images, it matched so perfectly. And it's just reading how rare it was. So I thought, well, what are the chances? So I went back to the pediatrician and I said, look, I may be crazy. Maybe all this is just a series of coincidences and this is who she is, but maybe there really is something more, and there's something more going on with her that can explain everything that's happening. So we did the connective tissue panel, and Isabella came back positive for vascular Ehlers-Danlos. She also has the splice type mutation, which we found out is the most severe form of VEDS with the lowest survival. It was at that time that we also learned about aortic dissections, spontaneous ruptures, spontaneous bowel ruptures, and kind of how life-threatening her condition is. We quickly moved into action with the help of the VEDS movement, and other families from across the country helped us put together Isabella's care team. So she's now followed by Dr. Hal Dietz at Johns Hopkins and Dr. Chelliah at Morristown. And it was shortly after her diagnosis that we experienced our first kind of event where she just fell and ended up breaking her nose. So not knowing kind of what to do now that we know the diagnosis, I called Dr. Dietz and he said, take her straight to the emergency room. So we went to Morristown's emergency room. I had my VEDS passport and a letter from Johns Hopkins explaining her condition and that she needs to be seen right away. Dr. Dietz's concern was that not so much her nose, but that there might be a possible brain bleed, and we should kind of get a CT right away to get ahead of the game. So we went to the hospital. This was May of last year, and I had my documents in hand, and we waited for 5 hours in the emergency room for her to get the CAT scan. And as a parent, I was trying to explain to the medical staff, like, no, she's trauma, there might be something else going on. And I know now what I know the risks that are associated. Is it just, can it be a brain bleed? Could it be another rupture somewhere else? And all these scenarios are going on in my head. And I remember thinking at that time was, I had spoken to several families within the VEDS community that have lost somebody, have lost a child just waiting in the emergency room. And I know I can't control. We can have the best medical team, and there is no doubt in my heart or mind that we don't have that right now. And I can't control a rupture or something spontaneous from happening to Isabella. But what is so hard is that knowing the spontaneity of VEDS, and I may lose her at some point, but I don't want to be left with, was there something more that I could have done? That grief of wondering, had she gotten a quicker response from the emergency team, would that have changed her outcome? And like I said, I know there's, without any proven treatment, those are concerns. You know, knowledge is power, but it's also crippling in the event that if you're just sitting there waiting for the team to know, and just knowing that it's so rare. Also, when you have everything in hand, it is scary. So that is kind of our story with vascular EDS. So I'm hoping today my goal is not just knowing kind of the missed signs that sometimes it is. If you look at them in isolation, they might be normal, but if you put them together, maybe there's something else. But also more importantly is just kind of giving hope that if I do come into the emergency room, that she will get the care that she needs, so she has a better chance at survival. And that is my hope for today. So thank you, everybody, for giving me this opportunity.
Great. Thank you, Heidi, so much for sharing your story. It's really powerful, and I think it's really important because it's such a rare condition, and I think most people don't know a lot about vascular EDS. So we're going to now switch, and I'm going to talk a little bit about vascular EDS, and Katie's going to talk about the end about her personal experience. But we're going to review vascular EDS for those of you who did know about it once or who never really learned too much about it. So are my slides visible?
Yes.
Yes.
Perfect, great. So, so as was mentioned before, we're going to talk about vascular EDS, which we call VEDS, and which is a very high-risk vascular condition, and it's very hard to recognize. And so we're hoping that by bringing this to you guys, you can possibly recognize the next patient that comes across and know how to care for them. So I've noted a disclosure, I am on a scientific advisory board for a clinical trial for VEDS, which I won't be discussing today. So the objectives of this are to recognize when to suspect VEDS as a diagnosis, to know how to construct a care team for families affected by VEDS and other rare conditions, and to identify risk stratification tools and treatment strategies in VEDS. So what is vascular EDS or VEDS? So first of all, I'm going to take a step back to Ehlers-Danlos syndrome types. So there are many types. This isn't even a complete list of what we call Ehlers-Danlos syndrome, and this is really an old nomenclature of people who might have had some flexibility, but they're not really that related genetically. The three, as emergency room doctors, pediatricians, cardiologists, that we will see the most and think the most about and that have the most likelihood of affecting the cardiovascular system are these three: hypermobility type, classical type, and vascular type. And what most people think when they hear EDS is hypermobile. These are the people who are super flexible, they have autonomic dysfunction, they have postural orthostatic tachycardia syndrome, chronic pain. They can have some mild cardiovascular features besides the POTS. Usually they have a normal echo, or maybe it's borderline aortic root dilation. The etiology is not known. There's not a genetic focus for hypermobile EDS, and they do not suffer from aortic dissections. So this is 99% of EDS that you're going to see. Classical EDS is pretty uncommon. It's caused by a different gene in the collagen 5A1 and collagen 5A2 genes. These are people, they're not as flexible, but they have abnormal skin. So they get hernias, atrophic scars, they can have abnormal prolapse, they can have joint hypermobility, but it's not like in the hypermobile group. These are the ones that have stretchy skin. They can also have borderline root dilation, and they have this cigarette paper-like skin too. So this is classical EDS. This also does not cause aortic dissection. So the cardiovascular involvement in classical EDS is minimal. What we really want you to distinguish this from is vascular EDS, which used to be called type 4 EDS, and we're going to do a deep dive today. But big picture is the unique features of VEDS are that they can tend to have very easy bruising and bleeding. They're prone to organ or vessel rupture, acrogyria, which is aged hands and feet, prominent eyes, thin lips, and small chin. And these are just some pictures I'm going to show you later. It's actually very, very hard to recognize the facial phenotype in VEDS. And the aortic pattern, the challenging thing in vascular is they, like classical and like hypermobile, they tend to have a normal echo, but despite a normal echocardiogram, they can have massive aortic dissection or rupture or tear of any of their small arteries, small or medium-sized arteries as well. So while we can dismiss, especially as a cardiologist, we can dismiss hypermobile and classical EDS often from clinic or see them every few years, patients with VEDS are at risk at any time in their life of sudden death from vascular rupture. So what are the genetics? So this is an autosomal dominant inherited disorder. It's caused by a change in type 3 procollagen, which is called the COL3A1 gene. It's autosomal dominant, so you only need one gene to have affected. And even though it is always genetic, it's not necessarily inherited. So it can be inherited from a parent, or it can be spontaneous, a spontaneous mutation called de novo. Now, about 50% of the known COL3A1 mutations we see are inherited and 50% are de novo. And this is super rare. This is estimated to be 1 in 50,000 to 1 in 200,000. Now, that's very different than hypermobile EDS, which is expected to be 1 to 3% of the population, 1 to 3%, 1 in 100. So collagen is this tough fiber-like protein that makes up about a third of the protein in our body. And type 3 collagen is all over our body, and it's extensively in skin, lung, uterus, intestine, and the vascular system. And as you remember, I said that type 3 collagen is what's altered in vascular EDS. And so basically there's this triple helix that collagen forms. And you need normal structure of type 3 collagen to make these curves, to make this triple helix. And this forms these collagen fibrils, which form collagen in your body. If there's an alteration in this protein, this doesn't fold the right way. It doesn't make this right triple helix, and then you have more fragile collagen type 3. So what about it in kids? So in children, the features most commonly identified as the reason for testing are one, family history. A parent, unfortunately, and in my clinic, I follow about 60 children. One of the most common reasons I see is that a parent has died at a young age. And we get testing and we find out that the child is affected. And they can also, not everyone has signs, but they can have signs. And these are, like Heidi shared with us, easy bruising, hematomas, thin skin. They can have joint hypermobility, but it's never joint hypermobility in isolation. And unlike adults, presenting with a critical event, a dissection, a rupture, a bowel perforation is uncommon. It definitely can happen, but that is less common. Versus adults, the vast majority of adults, because it's so unsuspected, present with a life-threatening event. Now, it is very common for child abuse to be suspected given significant bruising in some cases. So a lot of these children, like Heidi mentioned, you can just touch them and they'll bruise. And so at least 4 of my families have had Child Protective Services called on them. And it's something to think about if you're examining someone. You know, these children do not have increased risks of fractures. So if you're examining a child that doesn't have that you're worried about child abuse, doesn't have long-standing fractures, they tell you a long-standing bruising history, please keep this in your differential. So what are some things that we can see? We're going to go through lots of the features that help recognize. So infants with this condition can be born with club foot, hip dislocations. They can have amniotic band syndrome or limb deficiency. Also reported in the newborn period are a pneumothorax, a collapsed lung. They're more prone, especially upon CPAP. And pyloric stenosis, we don't know why pyloric stenosis, but it seems to have an increased prevalence in VEDS. So I want to show you this. So this is a facial pictures of some of the patients who have been lovely enough to donate pictures for our research and for education. And as you can see, at first glance, these kids are adorable. They're super cute. They don't look dysmorphic like we think of a lot of genetic syndromes, but I am going to try to point out some of the facial features. So it's very common to have these large, deep set eyes. They often, if you can see, have an extra fat pad underneath the eye or really dark circles under the eye because the eyes are so deep set. It's very common. They're very prominent. We think it's actually lack of fat sort of around the eye makes them look more deep set. They tend to have a thin, pinched nose, a smaller nose than would be anticipated in their family, and also small, thin lips. You can see that almost everyone in this picture has very thin lips. Tend to have a small chin. They can develop gum recession and fragility even as a child. But I tell you, it's very subtle. You know, we say, okay, the features are big eyes and a small nose and a small mouth. Well, for a lot of people, this is what makes you, that's like a very attractive finding. So it can be very, very hard to pick up. They look nothing like Marfan syndrome, nothing like Loeys-Dietz syndrome. They tend to look non-syndromic, so the features can be very subtle. Now, these are some of our adults in our studies, and you can see as they grow, I think it's even harder to pick up the features. So these are some young adults and a couple of older adults. You can see they still have the prominent eyes and the narrow nose. One thing I wanted to point out is if you've noticed the last two pictures, almost everyone I showed you is either Caucasian or Hispanic. And there is this picture of Crystal, a woman, unfortunately, we lost a few years ago to VEDS, who's African American. But in our research studies, in our registries, in our cohorts, we are definitely deficient of people of African American heritage, and there's no reason genetically that it should be less prevalent in those communities. And what we're all afraid is happening is that this is being under-recognized because one of the first cues is thin skin and see-through veins, and then it's being under-recognized, and we're probably losing people without a diagnosis. So just something to bring up, but something we're constantly working on is trying to increase knowledge to recognize this in people of darker skin. So what are the most common features in children? So like I said, prominent veins, prominent eyes, easy bruising, and hindfoot deformity, or it could just be flat foot. So these are the most common, but we're going to go through a few of the other features. Now, a secret piece of history that you're taking is, as Heidi mentioned, almost 100% of my patients sleep with their eyes open. I know that I don't even think this has a medical name, and we don't really understand why, but it's a really, really common feature. And if it's something you're suspecting, ask them this, and parents will be blown away. But that's extremely common in children with VEDS. So this is a mentioning of the skin. You can see in all three of these people, the veins are really easily seen. The most common place is the upper thorax or the lower back, and you just see veins everywhere. Now, again, this tends on people of fair skin, it's more evident. The skin is also soft. It can be very soft and doughy, but not stretchy like in classical EDS. And it's very prone to easy bruising, tears, and your hands also look very aged. If you look on the far right, this is a hand, that looks like a hand could be from a 6 or 7-year-old, and I think this is from a 20-year-old. So, and if you look at this foot, this is showing a large bruise, but this is from a grade school child, and you can see that it's, the limbs look older. So one thing that's also interesting, and this is research that we're about to publish, is preterm birth is actually much more common in VEDS than in the general population. So if you look at this bar graph, the right bar is the general population. Preterm birth before 37 weeks, is prevalent in about 14.8% of the population. When we look at VEDS, it's almost 50%. And we think this is because the amniotic sac is actually made from the same tissue as the fetus, and that's the same DNA. So we think the amniotic sac is actually much more fragile because the collagen is not normal, and that's why they most likely have early preterm delivery, but it's 50%. So another thing in your history taking to increase the suspicion. So let's talk about echocardiography. So historically, if you look at papers on VEDS, they'll say the echo is normal, and for the most part, yes, that's true. If you look here, the first pie chart is percent of echo abnormal. So 73% of kids, around 3/4, will have a totally normal echo. Now, the abnormal incidence is actually increased, though, compared to the normal population. And if you look at our cohort, we do see some subtle abnormalities. So aortic dilation alone is present in about 10%, but it's subtle. CHD actually has increased prevalence. So some of the congenital heart diseases that have been found in kids with VEDS or bicuspid valve seems slightly increased above the 1 to 2%. Epstein anomaly, ASD, subaortic stenosis, and left superior vena cava. Now, none of those are in the same cardiac family, so we don't really understand why that's increased, but we do see that. And the likelihood of having both CHD and aortic dilation is also slightly increased compared to the regular population. So now we know someone has VEDS. What are complications or emergencies we need to worry about? So the biggest one is aortic dissection or rupture, or arterial dissection or rupture. So I'm going to go through, and I know you guys probably know this, but through the difference between aneurysm, dissection, and rupture, because sometimes it gets a little cloudy. So an aneurysm is a dilation of part of a blood vessel. So looking on the left, this is the arterial system of the body, and any of the arteries can be affected in VEDS. An aneurysm, this is an aortic root aneurysm, this is an ascending aortic aneurysm, is where the area is dilated but not torn. This dilation, here this is an example of a dilation in the iliac arteries. Now, this has 0 symptoms. You have no idea you have it. It doesn't cause any symptoms until there's a tear. So this can only be found on imaging. Now, an aortic arterial dissection is when there is a tear into the wall. So if you remember, the arterial wall has 3 layers, an intima, a media, and adventitia. If there's a tear, not through all 3, but through 1 or 2 layers, and someone bleeds into the wall and it causes this second lumen or false lumen, this is a dissection. This is an example of an aortic dissection, but it can happen anywhere in any of the arteries, and it creates 2 passages. So you have the true lumen and the false lumen, and this lumen can fill with blood, it can clot, it can also make this wall compress. So if this happens in a medium-sized artery, for example, the renal artery, you can have renal artery ischemia. Or if this happens in the iliac artery or femoral artery, you can have occlusion of blood to the leg and can have major symptoms and can be life-threatening. We can also have arterial dissection in the head and neck vessels. So this is an example of a carotid dissection, and you can see as the blood fills this false lumen, you lose blood flow in the true lumen, and this causes signs of a stroke, of an ischemic stroke. So these are very important. Now, sometimes if this is in the vertebral arteries a little bit lower and posterior, it can just cause severe neck pain without stroke-like symptoms. So now a rupture is when there is a tear through all 3 layers. This is when the blood is not going into the wall of the aorta, but is going directly out into the lung field, into the mediastinum. This can happen. I've lost patients from a subclavian artery rupture into the chest wall. And so this is obviously most people who have an arterial rupture do not survive, versus a dissection can be treated with emergency surgery if you get care right away. So the one thing is, if you suspect a dissection or rupture or an aortic aneurysm, an X-ray will not pick up any of these. An echo will only pick up the aortic root, but as I mentioned in VEDS, you can have aneurysms or dissections anywhere in the body. So doing echocardiography is never sufficient. And so you must use CT or MRI. Now, if it's urgent, a CT is what you need. If you're doing screening imaging, which is what we do in clinic, then an MRI is acceptable and especially probably preferred for children, given that there's no radiation. So there's something very rare called a carotid cavernous fistula that can happen, and this is almost pathognomonic for VEDS. So this is when you have your internal carotid artery passes through your cavernous sinus right behind the eye. There is a situation in which this can have a perforation and bleed, and it causes this bulging of your eye, redness of your eye. It looks like this, like an injection. It causes significant pain, blurry vision, weak eye movements, and this has to be embolized to be treated. This is an emergency, and if you see this, you have to think of VEDS. It's very high in the differential. So pneumothorax is actually quite common in VEDS, mainly in older children and young adults, and we've all seen pneumothoraces from multiple causes, but this should be considered in your differential. So if you see a spontaneous pneumothorax with no explanation, make sure to ask about bleeding history, family history, these other things we've mentioned. Now, they can also have complications, including hernias, especially in the groin, the inguinal area, and recurrent or subluxation of the joints. I have a young man that I care for in El Paso, Texas, and he has chronic hip dislocations, and they just keep popping out of his sockets, and he's had to have bilateral hip surgery for these. Now, one of the most scary things, and also often pathognomonic for VEDS, is intestinal rupture. So children can come in with belly pain. People say it's reflux, it's functional pain, but they can actually have outright perforation of the intestines and may have to lose part of their intestines. The treatment is usually to repair or resect the intestines. Sometimes it can be monitored if it's a very, very small and heals, but most of the time people need surgery and sometimes have to get a colectomy. So it's very important if you have a patient diagnosed with VEDS that they've met with either a gastroenterologist or a colorectal surgeon who's familiar with VEDS to so they know someone in the community if this does happen. So hematomas and vein ruptures are really common. You can have just these huge hematomas from minor injuries or just spontaneous. You can see these are 3 pictures from real patients that have VEDS. Again, you can see this mild acrogeria. So looking for these big bleeding episodes, and these do go away, but they're quite painful and can last weeks. So what about caring for a child with VEDS? What do we make? Heidi mentioned that she made her care team. So I took this from the VEDS movement site, which is one of the, as Katie mentioned, and you'll hear from Katie at the end, which is one of the advocacy organizations for VEDS. And this is the model they mentioned. Oh, this is the adult model. I'm going to modify it a little bit to the PEDS model. So it's really, really important to have a local advocate. That's usually going to be the primary care doctor, a local advocate for care. This is often a general practitioner, a pediatrician, and they really focus on the care. But they should have a network, a team of people who are familiar with VEDS. And in adults, this is a vascular surgeon, but as most of us know, there are not many vascular surgeons in pediatrics. Even at Texas Children's, where I work, we consult with a vascular surgeon at the adult hospital. So most cardiovascular care is provided by pediatric cardiologists for children with VEDS. So you have your pediatric cardiologist, you have your geneticist, or sometimes like in our program, this is a combined clinic, so we work together. You have a general surgeon or a GI doctor. This is someone who could treat the bowel perforation, and any other healthcare providers depending what the child's affected by. And the main primary care person can reach out to these people and get connected at any time. Now, sometimes natural connections just occur, so where the cardiologist or the geneticist forms more of this role, but we really want to make sure that someone who is close and has access to all of the hospitals, all of the care, is really involved with each child's care. You know, sometimes we'll have people call from another state and say, will you be my main cardiologist or will you be my main contact? And that's not really the safest thing to do. We are available to help consult, available to help guide, available at any time, but you really want to make sure the local healthcare system in your town, your community knows what to do and to encourage this for patients. This is there's not a lot of evidence about what to do in VEDS, so I will tell you what we sort of do when we have a patient with vascular EDS, how we care for them. So we make sure to confirm the genetic diagnosis, make sure it's a COL3A1 mutation and not a mimicker. We perform cascade screening. So this is testing relatives if indicated, because as we said, 50% of the time it will be inherited. We almost always start with baseline head to pelvis imaging, usually an MRA, just to look if we have any chronic dissections, any aneurysms that we were unaware of. So we think this is really important. If they're under 3, I might wait till 3 because an MRA needs anesthesia, but we don't always do that. And if they're very young, we'll offer a CT versus MRA because a CT does not need to be sedated. We talk extensively. Our first visit is usually 2 hours. We talk extensively to make sure families are educated about risks and warning signs and that they have an emergency plan. We do have some activity limitations, mainly for older children. I'm going to talk a little bit about beta blocker therapy. That I'm going to talk is a little controversial. In our group, we do give beta blocker therapy, usually labetalol or carvedilol. These are 3rd generation beta blockers. We do serial imaging depending on severity. So as we're going to talk a little bit about high risk versus low risk. But for patients who have a lot of features, who are high risk and older, we might do those MRIs every year or every other year. If we have patients who have a lower risk variant and don't really have easy bruising, don't really have a strong family history, we'll probably see them every year with an echo, but we won't do the head to pelvis imaging except every 4 to 5 years. We do try to minimize procedures, only procedures that are necessary we talk about. And when we do that, we make sure the team is all prepared and knowledgeable about what's going on. And one of the most important things we do is try to connect families with other families. You know, this is and hopefully you'll get this sense from Heidi and Katie, but it's an incredibly supportive, connected community. It's a really wonderful community that I feel blessed to be a part of. And I think that's a really important part of getting through this diagnosis. So then talking about risk modification, can we predict what's going to happen? So I'm going to briefly talk about the different severities of vascular EDS, but it's not perfect. So the specific mutation, the exact mutation in COL3A1, how it alters type 3 collagen can matter. So if the mutation just has if it has a lower amount of levels, if it's less than 15% of levels, you're more likely to have gut or uterine involvement at a younger age at first event. And then we also have what are called null variants, and this is where the entire second copy of collagen is missing. And so you have all your collagens normal, it's just a lower amount. If you have what's called these splice acceptor site, splice donor site, or glycine substitutions, these actually alter the protein so it's abnormal. The protein folds abnormally versus null, you just have less protein, but it's still normal. So this is the Kaplan-Meier survival curve, and you can see that patients that have a splice donor site or a splice acceptor site or even a glycine substitution have much worse survival than those with a null variant. And we don't even see people with null variants usually having any life-threatening events till their 30s or 40s, versus it can definitely happen in childhood in patients that have a splice site mutation or glycine substitution. So the good news is for pediatric providers is survival in children with vascular EDS is very high. This is a beautiful survival curve published by Dr. Peter Byers, who's sort of the world expert in genetics on this condition. And what this is the US population and the normal survival curve. This is the VEDS population with males being lower than females. But you can see that, you know, most of these events are happening in adulthood. So most kids, when we're caring for kids, are going to survive, but what we need to do is really help them recognize this, get them through surgeries safely, listen to parents, support families, and get them through. And this is definitely a doable thing. These survival curves are often also taken from the last 20 years, and we hope that we're modifying these curves. So, and there's an old mantra that says that you can't do surgery on these patients because their aortas are too fragile, their vessels are too fragile, but that's not really true. Even though it's difficult, it can be successful. These are some of the patients in my practice. So there's a 13-year-old who's had multiple aortic surgeries for aortic aneurysms, a 15-year-old who had his right subclavian artery ruptured in the PICU, thank goodness, and he almost died. We saved him, and he had a successful repair. A 13-year-old had a stent placed in one of his arteries into the intestines after dissection to prevent mesenteric ischemia, and he survived. And another 14-year-old survived after a near lethal rupture of the subclavian artery. And some of these have been written up. And one of those is not my case. One is from Belgium. So lastly, I'm going to mention this trial, and there's two other trials ongoing that I'm not going to go into, but this is a clinical trial published in 2010, published in the Lancet, done in Europe. And there's a beta blocker called celiprolol, and it's a third-generation beta blocker, so it's thought to have some of the main beta blocking effects plus vasodilatory effects. And they did a randomized controlled trial in patients with VEDS to see if they had less life-threatening events. Now, they enrolled 53 patients, so it was not a lot of patients between France and Belgium, and assigned them randomly to celiprolol or placebo. The ages were 15 to 65. The medicine was increased and titrated, and they were followed for 5 years. Now, so they ended up having 25 in one group and 28 in the other group, and they looked at how many patients had dissection or rupture of an artery. So in the drug group, 20% had an event, and placebo, 50% had an event. So this study was ended early. It was published in the Lancet, and it said, oh, this is a great success. Celiprolol prevents events. I don't remember if I put the Kaplan-Meier. No, I didn't hear. The problem was, going back into the study, there were some limitations of the study. First of all, not everyone had genetic testing. So the numbers were actually about half of this that actually had proven COL3A1. How they were surveilled might have been different. And so there's been some questions about this on the efficacy of celiprolol. So there's a lot of debate on whether celiprolol works to prevent dissections or not. And so different practices have different perspectives on this. And our perspective in our pediatric hospital at Texas Children's and the 2 adult hospitals in our community is that beta blocker therapy is pretty benign. Most people tolerate it pretty well. So in case it has an effect, we do prescribe beta blockers, but it's not a hill we're going to die on, especially if patients having side effects. You know, we don't really know. We're open and we're really excited about the trials coming up, but this is kind of the only potential therapy out there right now. Some people do use losartan just as a blood pressure lowering agent, but there's no data that helps either. So the conclusion of this study was that celiprolol might be the treatment of choice for physicians. And again, that is really different across the world, whether they're using it. France and Belgium are using it, and we use a different beta blocker in the southern United States. But in London, they use losartan. In Dr. Dietz's patients, I believe he uses losartan. And in the West Coast near Seattle with Dr. Byers' group, I think they typically don't use any medication. So I just wanted to walk through in our last couple of minutes before Katie speaks about a family story and just the importance of knowing. So there's a family that I care for, and I met this 3-year-old little boy, and he came to me with his dad and his stepmother. And he said, and I heard this awful story that his mom, when she was pregnant with him, you know, young, healthy woman, I think she was 22 years old, pregnant, athlete, went in with some chest pain and had massive bleeding and died in the emergency room at a hospital not too far from us. And it was totally unclear what happened. She had cardiac arrest, she had CPR. They did save the baby, which is my young patient, and no one ever knew what happened to her. It was totally unclear. It was a mystery to the family. It was very heart-wrenching and difficult to handle, also because no one knew what happened. And he came to me, the stepmom had seen lots of bruising and lots of bleeding on him, and CPS had been called, and they'd seen hematology, and hematology said, this doesn't seem like a bleeding disorder. Maybe you need to see someone who knows about genetic disorders. And they saw us. And he had all the classic features. In fact, his face is one of the ones I showed you earlier. And we diagnosed him with vascular EDS. Now, thankfully, his story ends up being very different. So in retrospect, we're pretty sure that his mother had VEDS. We don't have a way to test her. But, you know, she died in childbirth unknowing. Now, what happened with him, we met him when he was 3 years old. About 6 months later, his stepmom called and said he's got severe pain, his abdomen's really blowing up, I don't know what's happening. And we said, come into the emergency room right away. He had had to go to the potty and had run to the bathroom and had tripped on a plastic stool running to the bathroom, and then developed this massive pain and abdominal swelling. When he got to our emergency room, he'd had a bladder rupture. His bladder had just ruptured, at probably falling on a full bladder, which can be life-threatening, and we had to figure out what to do. But because we knew he had vascular EDS, we got the anesthesia team to be thoughtful about the anesthetics. We got the urologist and talked to him about being thoughtful about the type of repair. He put in a drain that lasted longer. He put in sutures that were slightly different. And he had a bladder repair and did fantastically. He's 9 now, and he's doing really well. And that could have gone way worse had we not realized he had VEDS, and he's a happy, healthy young man. And so it just shows you how knowing can really change the course for these patients. So in summary, I just wanted to remind you, so vascular EDS is rare, but it's very serious. It's the most severe aortopathy that is out there, highly lethal. It's caused by a problem with collagen formation, specifically type 3. The common features in children are thin, translucent skin, easy bruising, aged hands and feet, and the echo is usually normal, so don't be reassured by a normal echocardiogram. It's most often picked up in children due to family history, easy bruising, clubfoot, hip dislocations, and skin findings. And a CT or an MRI is best to evaluate for aneurysms, dissections, and ruptures, and X-ray is never the right answer. Knowing the diagnosis of VEDS can significantly improve outcomes. Surgery can be done if necessary, it just needs to be planned. And beta blockers may help prevent adverse events in vascular EDS, but we need a lot more work in the therapy realm. So thank you so much. I look forward to hearing from Katie. This is just a picture with 2 of the families I care for that are incredibly supportive, both to me and to the community. So thank you guys. I'll stop sharing my screen.
Thank you so much, Shaine. Can you hear me okay?
Yes.
Great. Okay, so my name is Katie Wright. I am the director of the VEDS movement, and I also have vascular Ehlers-Danlos syndrome. And I'm going to tell you a little bit about my story before I hop into some resources that are available for your patients and for you as physicians. So growing up, I had many of the features that Heidi mentioned about her daughter, Isabella. I had very thin, translucent skin. You can see my veins all over my body. I've had these like old looking hands most of my life. Slept with my eyes open when I was little, easy bruising, very easy skin tearing. All of these things were present throughout my life, including GI issues. But we never found an answer when I was a child. And so in 2016, I was 26 years old and had no idea that I had this condition. I'd lived my life with this big mystery that, never had an answer and was told I was healthy, and kind of it was in my head. In March of 2016, I woke up with the most severe neck pain I had ever experienced in my life. And I truly thought that I'd slept on my neck wrong, and that this is what people felt when they slept on their neck wrong. I really could not turn my neck in either direction. But my whole life I had issues. And so I was like, you know what? I'm going to power through it. I'm going to go to work. And I made it an hour at work. I got to work and made it an hour, but I really could not turn my head. It was just this incredibly severe pain. And if you had asked me at the time to pinpoint exactly where on my neck this pain hurt, I might tell you it was the left side, but truly I described it as if my head was going to fall off. That was the only way I could describe this pain. I drove home, barely made it. Every bump in the road, every time I pressed the brakes, it just felt like I was not going to make it home. But again, I felt like the most logical thing for me to do is go home and sleep it off, right? I had icy hot, I had ice packs, I had heat packs, and I was rotating them. Obviously, sleeping off this pain did not work. I went to my PCP, I think within 24 hours, and he told me that I probably pulled a muscle, and he prescribed me a muscle relaxer and an anti-inflammatory. Within a few weeks, I was out of those medications, and I was on the Tylenol and ibuprofen over the counter as much as I could take. Or this persisted for a couple months. I had scans on my neck. I went to a chiropractor. There were no answers for this pain. About 2 months into it, I woke up with this more severe pain, this room spinning sensation. I felt nauseous. I had my aunt drive me to the emergency room, where I waited just a little while to be told that I probably pulled a muscle and to go home and take some Motrin, and they never did a scan. So now we're in June, July of 2016. I finally wake up one day feeling better. It was the best day of my life, no pain for the first time in 3 months. And I was getting ready for work, reached down and picked something off of the floor, and instantly it was back. It was just this excruciating pain that it just felt like my head was going to fall off, and I could not figure out truly what I was doing wrong to cause this. But this pattern recurred for about 1.5 years, so I'm going to take you through some of these experiences that led to my diagnosis of VEDS. But it did become this pattern of, pain for 2 months or so, followed by a day of no pain, followed by instantaneous return of this pain with no explanation. Over the course of the next several months, I did move across country. I was living in Florida at the time, and then I moved all the way across the country to Washington State, pretty much as far from Florida as you could get, and had a new care team I was setting up, and this happened again. I went to physical therapy, like I said, chiropractic care. I was in a massage therapy thing once a week at least, all acupuncture, everything you could think of. And now we're in January of 2017. I had a new PCP. I told him what was going on, and we ordered he put in an order to see a vascular surgeon, as well as a nerve conduction study to make sure that I didn't have thoracic outlet syndrome. And the vascular surgeon, the thought was that they would order a scan of my brachial plexus and make sure that there was not an artery being compressed in that area. Truly, at this point, it had been almost 1 year since the initial onset of the pain. And I felt kind of like we were grasping at straws at this point. I went to lunch with my brother over the weekend and said, hey, this week I'm going to see a vascular surgeon, and they're going to do, this scan here. And he joked, very lightheartedly, that they wouldn't have to do a scan because you can see all the veins in my body anyway. And it was really funny to us because it had been true my entire life. But I went home that afternoon, and I felt truly convinced that somebody had missed something at that point. And throughout my life, I had had this feeling that somebody was missing something, and I would, you know, push for a test and it would be normal. I had been tested for scleroderma 3 times in my life because of the way my hands look. You know, there were always these periods of, is there something wrong? And then no, there isn't. But this time I felt like there was absolutely no way that there wasn't something wrong. So I grabbed my box of medical records and I spread them out on my living room floor. This is maybe, I think it was about the end of January 2017 or the beginning of February 2017. And I started writing down things, kind of a combination of things that had always been wrong with me, along with things that just happened and didn't make sense. For instance, when I was 18 years old, I slipped on a little tiny bit of water that was drying from a mop, and I tore my ACL almost all the way through. In 2013, I had been experiencing a 1.5 years worth of something that looked like ringworm, and that ended up being something called elastosis perforans serpaginosa, where the elastin tissue is actually pushing out through my skin and making it look like ringworm. And the dermatologist at that time in 2013 told me, hey, you know, you might have Ehlers-Danlos syndrome. Sometimes this is associated with that, and you should go see this geneticist at Mayo Clinic. Well, in 2013, I was in my senior year of college. I had a 15-credit class load, and I was also working 40 hours a week. And at the time, I said, no way, I'm not going to drive to Mayo Clinic. I don't even have paid time off, you know, and this is like finals week. This isn't happening. And I put it out of my mind. I saw a geneticist in 2014, though, who told me that I did not meet the criteria for any form of Ehlers-Danlos, especially not the vascular type, and did not do any testing. So in 2017, here I am on my living room floor, and I find this little thing about elastosis perforans serpaginosa, and I see the little tiny note on there about Ehlers-Danlos syndrome, and I said, you know what, this is my most obvious clue. This is where I'm going to start. And I looked up Ehlers-Danlos syndrome. I found a reputable source, the NIH website, and I found vascular Ehlers-Danlos syndrome. And it was one of the most devastating moments of my life, seeing myself and every feature of myself on this website. It had the translucent skin, it had the old looking hands, it had the small hypermobility, like of my small joints. It had the bruising. At one point, I got 15 stitches from a cat jumping off my lap. And it also told me that my median life expectancy at that time was 48 years old. So here I am, living across the country from where I had seen that geneticist in Florida and trying to get a genetic test again. For 3 months, I tried to get a genetic test from my local doctors. I had a vascular surgeon that I saw for thoracic outlet syndrome. I basically bombarded him that week and said, hey, by the way, I think I have vascular Ehlers-Danlos syndrome. And he was like, why would you think that? And after telling him, he said, you know what, I think you might be right, but he couldn't order a genetic test. I spent really 3 months devastated trying to find an answer, and eventually I called in a last-ditch effort the geneticist I had seen in Florida in 2014 and basically begged them to look up my file. Told them I thought they missed this. A day later, they called me and said, you know what, we're going to send you a genetic test. I got a genetic test in the mail, and I was on a waiting list at this point, I failed to mention, to see the geneticist locally in Washington for a 1.5 years out. So this is why this was such a desperate feeling. But on May 3rd, 2017, a month after my 28th birthday, I did get genetic confirmation of vascular Ehlers-Danlos syndrome over the phone by the geneticist in Florida, who had originally told me I didn't meet any of the criteria and didn't need genetic testing. This got me pretty fired up. And this is why I'm advocating. But in a couple weeks, I saw the geneticist in Washington, told him about this neck pain that I was experiencing. And I was doing all sorts of stretching. Like I had learned things from the physical therapist and my massage therapist and the chiropractor. And I was really very dedicated to trying to solve this problem for myself. And he said, you know, it might be an artery dissection. Just hang on until you see the expert vascular surgeon, and maybe don't do so much stretching for a little while. So I stopped. And within a month, I started to really feel better. I saw the vascular surgeon, unfortunately, not until September of that year. So in September 2017, I had a CTA of my head and neck that showed that I had had an internal carotid artery dissection in my left internal carotid artery. And I had a nice little pseudoaneurysm there. that was from that dissection. It was an aneurysm that had formed from the tear in the artery. And this is what had been causing my pain for the last year and a half. So that is how I got involved. I'm going to go ahead and share a presentation with you now. But obviously this really did get me very fired up to advocate for other people with this. I truly felt like I shouldn't have gone through that, but I felt even more so that nobody should go through that. And if they're going through it, they shouldn't go through it alone. So in 2017, I started this YouTube channel where I started advocating for VEDS. It was a very vague idea at that point. Like really, I was very emotional, raw, and fired up. And so a lot of my older videos are just me blabbing away. But now there's about 1,050 people across the world who subscribe to this channel. And I use it to advocate for this condition and share information about my life and other people's life with this condition. The most close thing to me, though, I would say, is the podcast. In April of 2018, I started this podcast called Staying Connected to talk to other people who are impacted by VEDS. And these stories, I really encourage you to go and listen to them. They're very raw, very truthful, and it's a really good look into what people are actually living with this condition. To date, there are 54 episodes of the podcast out, and unfortunately, a few of the people that I have talked to in the last 4 years have passed away since their episodes were recorded. And I will say the podcast, the YouTube channel, any of my blogs are not associated with the Marfan Foundation or the VEDS movement. These are just things that I do in my quote unquote free time. Heidi Green, who you heard from at the beginning of this presentation, shared her and her daughter Isabella's story on the podcast earlier this month in April of 2022. You can find that on the website translucentone.blog, and you can also find it on all major podcast players by searching for Staying Connected. Really grateful to Heidi for sharing her story on the podcast and raising awareness, and for organizing this Grand Rounds presentation. She's truly growing into an amazing advocate, and I'm so grateful to know her. So now I'm going to share some resources with you that are available through the VEDS movement. In late 2019, I actually joined the Marfan Foundation to start a VEDS division, which is now known as the VEDS movement. At the time, it was just this idea that we were going to do something for VEDS, and we did. So these are some things that you might see patients come in with or have available to them through the VEDS movement. One of the things that we did very early on is do this emergency preparedness kit. This is something very close to me that I felt was very important for people to have for themselves. Since my diagnosis of VEDS, I've had 5 transient ischemic attacks or mini strokes, and also in October of this past year, my spleen ruptured spontaneously. After my diagnosis of VEDS, I truly thought that my battle was over, that people would know about VEDS and I could just go to the emergency room and say, look, I have VEDS, and they would know what that means. But I very quickly found out that that was not the case. And so this emergency preparedness kit was really developed to help people affected by VEDS or parents of kids with VEDS be as prepared as they can be for emergencies. It has a checklist to help them compile all their medical records. It contains a letter to the emergency department, which I'll show you on the next slide. It has a wallet card. There's a recorded information line, a fact sheet for the first responders. This is really packed with tools to help them be as prepared as they can be in an emergency. This is what our letter to the emergency department looks like. We developed this alongside the medical experts on our professional advisory board, including Dr. Shaine Morris, who you heard from today. So you may see somebody with VEDS bring this letter with info about this condition to the emergency department, and this is a real thing. They didn't make this themselves. You know, this is a real thing developed alongside our professional advisory board to help people in an emergency. And it does contain the information about some of the medical experts so that you can reach out to them if you have questions about this condition. This is a picture of the wallet card. It folds into about a credit card size. And again, it has pretty much the same information. It just really drives home that point that these emergencies are known to happen with VEDS. And if somebody with VEDS presents to the emergency room, it's very, very important to rule these things out before sending them home. And for our patients, we've done a lot of webinars since we started the VEDS movement, including on vascular surgery, genetics, gastrointestinal surgery, management of VEDS in children, creating a care team, ABCs, like there's so many, and they're all available at thevedsmovement.org. There are too many to put here, but I think that not only are these important for the patients to have, but if you as physicians would like to go look at them, I think that's also helpful as well. There's a lot of information in these webinars. We also have a lot more resources for individuals, including support groups. As Shaine mentioned, it's really important for families to connect with each other, and we do have a very, very connected community with this condition. And I think it's pretty unique, I think, to this condition, how connected people are with each other. So we have virtual support groups that meet monthly. There's a help and resource center that is staffed by a registered nurse that can help get patients answers to their questions from the experts. There's events to meet others and the experts. There's research opportunities, conference. It's all available at thevedsmovement.org. And I really encourage you to recognize this condition and also give people this information so they can get the most support they possibly can. We recently developed this information line for emergency physicians, so now we're just transitioning into some of the resources available to you. This is a pre-recorded line with basic information about VEDS for medical professionals to know in an emergency. It's also available in the form of a fact sheet at thevedsmovement.org/emergency. And we encourage people with VEDS to give this information to the emergency department. It's just another tool for them to get the information across to the hospital what they're dealing with. This line is not monitored and does not help them decide if it's an emergency. It's really truly a recorded line with just information about VEDS, very basic information. And we do have a continuing medical education course. This was developed by the VEDS movement, our professional advisory board, and the Sullivan Group, which is a group that really specializes in CME offerings in high-risk situations and like risk management. And it really focuses on signs of VEDS and the medical emergencies associated with them. So it has some cases and examples of what might come in, and it will give you 1.5 hours of CME credits. I believe we recently had this edited to also provide credits for nurses. I think it's CEUs. So those are available as well. So really, thank you for having us today. I really appreciate your dedication, and I hope that this really helps you learn and recognize VEDS in your patients.